It's a huge pleasure to introduce Professor Helen Minnis. She's a colleague of mine. We've been working together for many, many years. And I have to say that I can't think of many people that I enjoy working with more than with Helen. So, she's, as far as I know, the only professor of child psychiatry in Scotland. She came to do a Viva, PhD Viva in London. So we had to use this opportunity to invite Helen to speak about her expertise.
Yeah, so welcome everybody. I'm going to talk about untangling complexity. And I mean, I know that many of you work with very, very sort of challenging, complex young people. And I'm going to talk about trauma and a lot of other things. So I'm going to start with something that many of you probably already know. And that is that there's an association, certainly in Western countries, between childhood adversity and mental health problems. So this is not surprising. We kind of have known this for decades. This was more surprising, and that was that there is a dose-response relationship between the number of childhood adversities and heart disease, and also cancers and all sorts of things. So one way of looking at this is that the bigger the load the child is carrying, the bigger the risk. But I'm going to come back to this. Because there are actually only very few problems that are really, that we can be confident about as following on from maltreatment, that are specific. And so I'm going to give you a little kind of case vignette. This was a boy that I saw a number of years ago. He was 9. He was withdrawn and contemptuous of his adoptive parents since about a month after he was placed. So things all seemed quite good before then. They described him as resisting the relationship. He would never go to them for problem solving or for comfort. He would frequently dissociate, and they warned me about this, and I could see that as he came into the room, that he would sometimes just go blank. And the adoption was on the verge of breakdown, and that was partly because the parents were feeling so isolated because no one else could see the problems. He fulfilled diagnostic criteria for reactive attachment disorder, which is characterized by a failure to seek and accept comfort. And that's actually quite a rare diagnosis for a child that's actually in an adoptive placement, because it's supposed to melt away when you're in a nurturing placement. So we've written up just a case series of 3, all boys actually, 3 boys who had persistent reactive attachment disorder despite being in nurturing placements. So it's rare, but it does still happen sometimes. So as I said, reactive attachment disorder is characterized by failure to seek and accept comfort, emotional withdrawal, hypervigilance, highly contradictory and ambivalent responses, particularly in the context of relationships. We did a prevalence study looking at both reactive attachment disorder and its kind of sister problem, which is disinhibited social engagement disorder, which is characterized by indiscriminate behaviors. And what we found was that, as everyone had said, reactive attachment disorder is very rare in the general population. So we screened 1,700 6 and 7-year-old children in Glasgow, in quite a materially deprived part of Glasgow. And we only found 1 child with this diagnosis. And the reason that we think this is rare in the population is that it does seem to arise from abuse and neglect. We think that the reason that reactive attachment disorder is rare in the population is that it's not that uncommon in children coming into foster care in the early years. But for most children with this problem, it melts away as soon as they're in a nurturing placement. And we don't know why sometimes it doesn't. So I'm going to come back to that. But the other disorder, yes.
Does it melt away, or does it come up in a different development stage?
It seems to actually melt away. So it's quite remarkable. And Charlie Zena from New Orleans has done a lot of work on this. And it does seem to be almost like these are children who kind of get warmed up in a nurturing placement if they're there young enough. So I'm talking about children who are 1, 2, 3, 4, that kind of age. And my hunch is that if it persists longer than that, it's probably harder for it to melt away. I also wonder whether there may be a kind of neurodevelopmental underpinning for some of the children as to why it doesn't melt away. But that's not the case for the other maltreatment specific disorder, which is disinhibited social engagement disorder. So this is a colleague of mine, Rachel Pritchett, in an orphanage in Kailicha, which is a shanty town outside Cape Town in South Africa. But she experienced what I experienced as a junior doctor. I ended up just through a travel bug getting a job in an orphanage in Guatemala. And this is what you experienced. You literally couldn't walk forward until you peeled off the young children because they would just crowd you. Has anyone experienced that? Some of you have. Yeah, you've experienced it in Ukraine in the big institutions. Where have you seen that? Right. So it's something that you see in children who are in orphanages, for example, and it's different from reactive attachment disorder in that it seems to be quite persistent. So there's been some big studies of children that were in those awful orphanages in Romania, and they've been followed up into adulthood. And if they had this indiscriminate behaviour in childhood, they often still have a form of it. So that's much more persistent. Don't ask me why, because I don't know. So in our prevalence study, when you looked at reactive attachment disorder and disinhibited social engagement disorder together, the prevalence was about the same as autism. So these disorders are not incredibly rare, actually. And they're particularly not rare in certain clinical populations. So a colleague of mine, Kate Moran, did a study in forensic CAMS. So she just did a prevalence study of all of the young people in Glasgow who were with a team that specialised in children who had both mental health problems and criminal justice involvement. And actually 20% of those children had reactive attachment disorder. And RAD is being thought of as an infant diagnosis. So Charlie Zena, for example, who's done a lot of work in infants, was very skeptical and said, what does it look like in young people? But, you know, failure to seek and accept comfort is actually quite obvious if you're looking for it. You know, hoodie over or the hair over the face. And what you sometimes notice is young people who apparently have perfectly ordinary social relationships until you talk about relationships, even friendships, and then you'll get 4-letter words perhaps. So I can see some nods. So it's not very uncommon in that population. And we haven't published this yet, but we've done a much bigger prevalence study in a prison, a young offenders institute. And again, reactive attachment disorder was really quite common, as was disinhibited social engagement disorder. And it's so frustrating because our sample size wasn't quite big enough because of COVID. We had to stop recruiting. But there was a hint towards these disorders actually being associated with criminal behaviour. And that never occurred to us, because with disinhibited social engagement disorder, why would indiscriminate behaviour make you get involved in crime? But I wonder if it's just that you're more likely to get caught. You know, if you're indiscriminate and you're not very good at working out who you should trust and who you shouldn't, if you were a young guy and you see some older teenagers and they're about to rob a shop and they're like, come on, you can imagine that if you're indiscriminate, you might decide that was a good idea. So, you know, we don't know, that's just me speculating, but of course, we tend to think about post-traumatic stress disorder when we think about children who've experienced severe early adversity, particularly abuse and neglect. The thing about PTSD is it is a disorder which you see in children who've been abused and neglected, but it's not specific, because of course you can develop PTSD from a bus crash. And actually, I've just been examining a PhD this morning by the wonderful Stephanie Lewis, who really, I mean, she has just written about this in such a clear way that when a young person has experienced trauma, more common disorders are even more common than PTSD. So actually depression, substance misuse, and actually conduct problems as well, particularly in boys. So these are all things that can arise out of abuse and neglect and other traumas. It's not just abuse and neglect, bullying, neighbourhood violence, but it tends to be the interpersonal types of trauma that are particularly linked to these diagnoses. Yeah, so this is Stephanie's work. So what she has shown, I'm just going to take you through this. What she found was that in the population, and she used an absolutely fantastic data set where they had followed up 93% of 18-year-olds from early life. I mean, it's an incredible data set. And what she found was that a third of 18-year-olds have experienced trauma using the strict definition of events that are or feel life-threatening. And what she found that if you've been trauma exposed, so this is the green line, then you are at increased risk. So if you weren't at increased risk, this would be 0. So you're at increased risk of a whole range of mental health problems, anxiety disorders, major depression, psychotic symptoms, ADHD, conduct disorder, alcohol dependence, cannabis dependence, nicotine dependence. And then within that group, about 1 in 8 of those who've experienced trauma actually have PTSD, and they are at even higher risk of these other disorders. So if you've got PTSD, you're at much increased risk of particularly substance misuse and psychosis. I mean, psychosis isn't that common, thank goodness, but you know, I was asking Stephanie today, what is the relationship between PTSD and psychosis? Nobody really knows, but it's just good to remember that these things sometimes go together. I feel as if I've thrown lots of information at you. Has anybody got any questions before I go on?
I was just wondering, would this not potentially fall more under complex PTSD if it has happened in the early years, and then would stuff like alcohol dependence be more complex PTSD?
I will. Yes, such a good question. You're anticipating my later slides. I'll come to that. Yeah, I'll come to that. And this is just the other side of that picture. So self-harm, suicide attempts, violent offences, and also this really got me, being not in education or training. Employment, education or training is also more common, both if you've experienced trauma and if you've got PTSD. And yet, only 1 in 5 had contact with a health professional. So, you know, big question is why. And we were discussing this morning, you know, could this be partly because one of the symptoms of PTSD is avoidance? But actually, it looks as though even if your trauma-related problem is depression, then you're also not very likely to have that diagnosed either. So I don't know quite what that tells us. We also have wondered a lot about stigma, because if you are female, then you're more likely to have PTSD, but you're less likely to have it diagnosed. And we also wondered about Black and minority ethnic children as well, but there wasn't enough, wasn't a big enough sample to be sure about that. But there's something going on here in terms of perhaps professionals' attitude to certain types of children and what gets diagnosed. And one of the things that I've been really interested in is children who have a history of adversity. And this is just one paper. This has also been shown for ADHD, that if you have a history of adversity, you tend to have a delayed diagnosis of a neurodevelopmental problem if you have a neurodevelopmental problem. And I think this fits in very well with my own clinical experience, where if a child comes from an area of material deprivation, for example, or if they've experienced a lot of trauma, whether or not they've got trauma-related symptoms, sometimes we tend to think, well, no wonder they're having all these behaviour problems, you know, and we kind of explain it away without actually doing the formal assessment and just checking what's actually underlying all of this. I can see some nods. So stigma is a barrier. There's just no two ways about it. So beware of thinking, oh, this is social, or my goodness, if I lived in that housing estate, no wonder. Maybe you're right, but maybe it's ADHD or autism. So this is wonderful work that's been done by Rachel Hiller on complex PTSD, and she really wanted to know whether children who were in out-of-home care, so in foster care, residential care, who had complex PTSD had the same kinds of problems as children who had simple PTSD. And interestingly, what she found was that the severity of the maltreatment that these young people had experienced, and they had all experienced maltreatment, was actually not a robust predictor of PTSD. So why do some children get PTSD and others don't? And it doesn't seem to be to do with the severity. But actually, what did predict complex, either simple PTSD or complex, and just for the, you maybe all know this, and if not, forgive me for explaining, but simple PTSD is PTSD that's related to a single event. Complex PTSD, and there are slightly different definitions, but it tends to be repeated interpersonal traumas. But what predicted both simple and complex PTSD was maladaptive appraisals, memory quality, and coping. So things like the world is not a very nice place would be a maladaptive appraisal, or qualities of the way that you remember the events. And also, and I found this really interesting, young people who seem to be particularly good at suppressing their thoughts, that's a bad prognostic sign. So some of the coping mechanisms seem to actually allow PTSD symptoms to persist, whether it's complex or simple. And actually the maladaptive appraisals, like the world's not safe, exacerbated by maladaptive coping, thought suppression and avoidance, were not a good mixture in terms of prognosis. But what Rachel Hiller's take on all of this is that even if the trauma has been complex, and even if you would define it as complex PTSD, because the cognitive and thinking styles are the same, this should be just as amenable to evidence-based treatments like trauma-focused CBT. Interestingly, though, I was asked to be a discussant on one of these ACAM journal clubs with a service user who was really interesting, a young woman, Aishat, who had been in foster care, and she and I both felt that this wasn't quite enough, because certainly some of the young people that I've worked with who've got complex PTSD, they often also have relationship-focused difficulties, which are just a bit different. So this is just my speculation, but this is just a little diagram looking at complex PTSD symptoms. And if you look at this bit of the shape, you've got flashbacks, nightmares, re-experiencing, avoidance of reminders, hyperarousal. That's all your traditional PTSD. And even up here, you've got your somatic distress and your altered intention and consciousness. That's all things that we would recognize for someone that's been in a car accident, for example, and has PTSD related to that. Then in the definition of complex PTSD, you've got things like struggling to regulate your emotions, difficulties with relationships, difficulties with your belief systems, loss of faith, trust, etc. I wonder whether these are actually RAD and DSED symptoms. So certainly with little children with reactive attachment disorder, it's clear failure to seek and accept comfort, but in adolescents and adults, that can often kind of morph into trust issues, actually, not wanting to seek help. And then alternatively, if you've got a little child with indiscriminate behaviors, that in adolescence and adulthood can really manifest as boundarylessness. So I just wonder whether this is PTSD and this is something else that maybe needs a slightly more relationship-focused approach, but we don't have evidence-based treatments for reactive attachment disorder and disinhibited engagement disorder yet, although we're doing a trial looking at it, so watch this space. I'll be able to feed back in about 3 years. But it was so interesting talking to this fantastic young woman, Aisha, who, you know, she just thought, you know, there's a bit of this psychopathology that we're just not quite targeting with the complex PTSD. And one of the things we discussed today was that's not to say that you shouldn't use trauma-focused CBT. It's just that you may still need to do more even once you've done that. So back to this thing about the bigger the load, the bigger the risk. It's not the end of the story, because only about half of those children who've experienced abuse and neglect actually do develop mental health problems. And it's really hard for us as mental health clinicians to remember, or researchers to remember that, because we only see the ones that come back. You know, so in mental health, you know, if we've come across a young person who's been abused and neglected, we'll be seeing them because they also have a mental health problem. We'll never see the other half who don't have a mental health problem. You know, and doing research, I had a very salient experience where we are doing this randomized controlled trial of where we're recruiting young children coming into foster care, and Dennis is involved in this crazy trial as well. But I got a phone call a few years ago from a social worker saying, listen, this little boy was sent home, even though the team who'd assessed him said he shouldn't have been sent home. He's now back in care, and he was so badly beaten that he had to go into the local paediatric hospital overnight, so very severely beaten. Do you mind, it's a really unusual request, but can you look at all your research data and just see who I should refer him to? The wee boy was 4 by this time. So we did that. We just went through everything with a fine tooth comb. We had all this video of the boys' interactions. You know, there wasn't a single symptom. And so I was able to phone the social worker back and say, well, keep an eye, but you know, there's no point referring for therapy because there's nothing to therapy. You know, and then you remember, well, actually, we kind of knew that, but we don't see those children. So what else is going on? And this is Jessie Baldwin and Andrea Dinesi's work, and they've done fantastic work on this. So this whole thing about ACEs predicting poor physical and mental health outcomes, most of that's been done asking adults to remember their childhood. And the problem with that, the way I describe the problem with that is that if you have 2 men who've experienced shouty fathers, and one's depressed and one isn't, they may have a different way, according to the one being depressed or not, in recalling the same degree of shoutiness. So one might say that was definitely emotional abuse, and the other one might say, well, it wasn't really, yeah, it's a bit shouty, but it was fine. So there's going to be a bias according to what you actually are experiencing as an adult, and it's a huge problem. So although ACE scores actually produce group differences, they actually they're not accurate at all in predicting what is going to happen to you individually. So you could have 9 or 10 ACEs and be fine. And I think that's really poorly understood, because a lot of kids who've been burdened in this way with adversity, which of course is a human rights violation in and of itself, so it shouldn't happen. But I really hate the thought that they are maybe being made to think, well, you're definitely going to have a terrible outcome. You know, you're going to die young, probably going to get heart disease. No, we don't know. You know, we really don't know. So the other bit that I find really fascinating is this whole thing about, we call it differential susceptibility. It's just a real mouthful. So I'm using I'm going to use a really, really crude analogy here. I'm going to talk about, so there's been lots of good longitudinal research that has shown that there are temperamental characteristics that you can, if you ask parents, they can tell you about their children. And these tend to be pretty stable through life. And there was a group of children back in the day that were described as having a difficult temperament. I mean, we probably wouldn't use that now because it sounds pejorative, but these are the children like I've got 2 kids, and, you know, perfect description of my daughter, who's really doing well, I should say. She's 25 and, you know, just out there beating up the world in a good way. But she had an absolutely classic, what Chess and Thomas, who were the people that did this research, would have called a difficult temperament. So she was the kind of little girl who didn't know night from day. She cried a lot. She had colic. She wanted to be held all the time. She didn't like change of temperature, all of this kind of thing. And then there are children who are much more easygoing, and that's just been demonstrated. And I like to call these guys, the diamonds, and these guys, the gold coins, because they're both really precious, equally precious. But the thing about this is a very crude analogy. I mean, very crude. But the thing about the kids who are more sensitive to the environment, like my older daughter, is that they are more likely to be tarnished if the environment is tough, whereas easygoing kids less so. So just to put this in a really, really crude way, even if the environment is negative, the easy temperament kids are more likely to cope with it, be okay. Not so much with our gold coins, more susceptible children. But the remarkable thing about these kids is if the environment is good enough, and it doesn't have to be perfect, these more sensitive children tend to be doing even better than the general population by middle childhood. And I mean, I think my daughter's a really good case in point. She was a tough little girl to look after. We were lucky. We had my parents near, lots of support, enough money. We weren't struggling with housing issues. And so it was fine, a bit sleepless at times. She is very feisty and she's now putting that to good use. She's out there doing her stuff. So these are not necessarily bad things. And then the other thing that I found really influential in my thinking about this was a paper that came out in 2011, and it's called the Adaptive Calibration Model. And I love this quote. Children have evolved to respond in biologically adaptive ways to harsh and unsupportive family environments, not just to loving and supportive ones, which is incredibly liberating. And again, it's a human rights violation to abuse a child. So don't get me wrong, I'm not saying it's a good thing. But the WHO has said that across the world, half of all children report having experienced violent victimization. So remember those dose-response relationships. The rate of violent victimization really varies a lot from country to country. And it's not just according to whether these are high-income or low-income countries. Within rich countries and low-income countries, the rate of violent victimization varies a lot. But the rate of things like schizophrenia really doesn't change very much at all. So there's not a direct relationship between these things across the world. And so one of the things I think we really need to kind of grapple with in the West is that positive or good enough environments ordinarily have some harsh elements. And I think that's really important because in mental health, I think we often worry that if a child has experienced anything bad, then they're going to be damaged. Actually, I just don't think that's the case. It's not the case in the animal kingdom. Be interested in your thoughts about that. Does that make sense to you? Do you come in and disagree? Yeah, go for it.
Can you give an example of the good enough environment that can have the harsh?
Well, so I think one of the things that's been really liberating for me about being a child and adolescent psychiatrist is that I realized that the range of parenting is really massive. And also if you've been lucky enough, I have to travel, but I've been amazed. I remember going on holiday to Spain and seeing all these families yelling at each other and waving and shouting, and that's just what they do. That's not unusual in Spain. Whereas in Sweden and Norway, people are much more reserved, and that just would not be seen as socially acceptable. I've also been really struck by, we know, I mean, there's really pretty good evidence that harsh parenting, properly harsh parenting, is associated with aggressive behavior. But there's all sorts of different ways of being harsh. And so my husband, for example, worked in Botswana for a couple of years, which is one of the most peaceful countries in the world, no history of war or violence. And he was a secondary school teacher there for 2 years. He didn't see any violence, it was incredible. And yet he used corporal punishment in the schools. So what's going on with that? And the behavioural studies suggest that that hitting children is at worst harmful and at best pointless. But what that really made me think was that actually kind of tapping a child, I'm not saying this is a good thing to do because I think it probably is pointless, but tapping a child on the back of the hand is probably an awful lot less damaging than yelling at them in a humiliating way in the supermarket. And I think what I really have taken from this research is that all of us lose it sometimes. All of us rush out of the door while our 2-year-old is holding their hands out and you're thinking, I've got to get my train, I can't. So, good enough parenting is not perfect parenting. And that's what NSPCC would describe as not good enough parenting, and certainly would describe as abuse, would be constant, persistent humiliation. So we all get it wrong. And that's fine, I think, is what I take. I'd be really interested to know what others think.
I think my background is on the child and adolescent mental health wards that I've recently done with half the children's nursing team, but I specifically work with leaders from care. And I think I had, obviously, for years working with young people, really complex presentations and really difficult times, and the majority of them in a crisis at that point. And then coming over to meet the leaders from care, and there were so many that didn't even know what CAMS was. And they've had really good upbringings with whether it's been through foster care, whether it's been residential. Don't get me wrong, there's lots that haven't, but meeting those young people that haven't had those experiences and had no idea of, some of the services are out there, and even some that had been referred to CAMS at younger years, but I wonder whether some of that was led through the professional thinking they need it based on what they've experienced, and maybe not what that child may have needed at the time.
I think that's such an important point, and I think we often kind of conflate the experience of trauma with trauma symptoms, and it's so important not to do that because people respond in such different ways. Implications: we shouldn't be deterministic about trauma, nor should we assume that people who've experienced severe trauma are in some way damaged or vulnerable. We don't know that. And actually, there's this whole concept, particularly in adult mental health, of post-traumatic growth. So there seems to be some research that if you haven't experienced any trauma at all, then you're more likely to have kind of unusual stress responses. Maybe you'll need a little bit. So I'm going to kind of fly through this bit because the methodology is a bit complex, but don't worry, because we made a little video where I asked the behavioural geneticists stupid questions, but I did some research, a group of us did some research with Lisa Dinkler, who's a behavioural geneticist, and we asked whether do children who've been exposed to maltreatment have more neurodevelopmental problems like ADHD, autism? Because I'd noticed that in my clinic. So in other words, if you've been abused and neglected, do you have more of these neurodevelopmental problems? And we asked about symptoms of ADHD, ASD, tic disorders, and intellectual disability. And the answer was yes. It was even more striking than I'd thought. So of those 4 symptom clusters, if you were in 3 out of the 4, you were nearly 10 times as likely to have an experience of abuse or neglect. So then the question was this caused by the maltreatment? Was this increased complexity caused by the maltreatment? And it was a twin study. I'm not going to go through this actually. It's all about whether monozygotic or identical twins or non-identical twins are more like one another. Look at the YouTube. But essentially, no. What the twin study suggested was that actually it wasn't the maltreatment that was causing this neurodevelopmental complexity. This was a huge surprise to me. So yeah, you can get the YouTube link. I'm asking Lisa silly questions because I was like, what? So it seems that there are additional genetic factors that are causing both the maltreatment and this neurodevelopmental complexity. And we wonder whether these could potentially be neurodevelopmental problems running in the family. So we've always thought about intergenerational transmission of abuse and neglect. Actually, I think a lot now about intergenerational transmission of ADHD or autism or whatever. And so we haven't proved this, but with my colleague Ruchika Gadwani, we've come up with this little model that we're calling double jeopardy. So we already know that children who've got neurodevelopmental conditions like ADHD or autism do tend to have greater problems regulating themselves. So if you've got autism and you've got sensory sensitivities, for example, or if you've got ADHD and you boil over easily because of impulsivity. And we also know that if you haven't had your stress responses regulated by consistent, good enough parents, not when I say consistent, they don't have to be perfect, then you're more likely to have problems with emotion regulation. So if you've got both, and we know from our research that these things kind of attract one another, unfortunately, one increases the risk of the other, do you have a double whammy? And could it be those young people with both that are at higher risk of severe mental illness emerging later in life? And we've got some evidence of this. So Ruchika led a study where we looked at children aged 9 in this same big twin study, but we didn't use it as a twin study here, we just used it as a big population. So the children within that population, age 9, who had neurodevelopmental conditions, and children who experienced traumas, mainly abuse and neglect. And then we followed them up to age 15, and we looked at symptoms of mania. And the reason we picked mania was because it's a symptom of a severe adult type mental illness. And what we found was that childhood traumas did increase the risk of mania at age 15 a bit, and neurodevelopmental conditions also increased it a bit. It looks as if they increase it a lot more, but we don't have a big enough sample to be certain of that. But if you have both, you literally do have double jeopardy. You've got twice the risk of mania symptoms. And we're looking at this in terms of physical health problems at the moment. I've got a student who's looking at that. But we've just been thinking, what on earth are the mechanisms here? And I don't know. But it's clearly an interconnected system, because this is the Bensonbrenner micro bioecological model, which is just a really nice way of thinking about a child and their world. So you've got the child in the middle with their genome and their immune system and all of their physiology. And then you've got the microsystem, which is their intimate relationships. And then you've got the mesosystem, which is their wider relationships, their extended family, their friends at school, their teacher. And then you've got the exosystem, which is like the neighborhood, where they've got decent public transport. And then you've got the macrosystem, which is things like the kind of religious milieu of where you live and how you fit with that, and community values, those kind of things. And actually, if you look at the individual, his or herself, with their genetics, what we know, and I'm a bit of a first-year student on this, to be honest, this is not my area of expertise, but I've worked with people who've explained it all to me. So you've got your stress response system here, the hypothalamic pituitary axis. But what I've learned over the last few years, I didn't know before, was that these regulate together. So if you kind of upregulate your stress responses, you automatically upregulate your immune response. They're kind of all the one system. And then you've got all of these aspects of your social world. And I've got a very simplistic way of looking at this, but if you're a child who generally kind of upregulates, if you've got a kind of hyper responsive system, and you get aroused easily and you throw chairs in the class, then compared to a child who downregulates and becomes withdrawn and quiet, you're going to have a different experience of your social world. You know, your teachers, your neighbors, and maybe the police are going to interact with you differently. So these things are intimately linked. I didn't do these lovely drawings, by the way, it wasn't me. And so we're looking at this in terms of physical. Go for it.
Sorry to interrupt.
No, not at all, no.
I mean, I've worked with disengaged young people for 15 years, and I'm working with asylum-seeking children who've been trafficked, in slavery, things like that. It just never ceases to amaze me how incredibly grateful they are in terms of like things like their attitude is what really strikes me. Perspective are the two things that come across in my experience of people who've gone through a lot of trauma and a very hard life. But for me, it's always their attitude and perspective are the two things that always strike me, that differentiates between the people that, in my experience at least, in my subjective experience, that differentiates people who are able to just function in a healthy way and get by and do really well, compared to people who really suffer in terms of their mental health. I'm just wondering.
Yeah, no, it's so interesting, and I don't think. Yeah, I no, absolutely. I have observed that, and I was having some really interesting conversations. A global health expert called Rochelle Burgess recently, because we were talking about our kind of individualistic Western societies compared to much more collective, extended family focused societies that many of our asylum seeker and refugees, young people have come from. And it's so interesting because her observation, she's Jamaican Canadian, so she grew up in Canada, and her family, her Jamaican parents both migrated there individually, but immediately set up a kind of extended family of non-kin. Fascinating. And certainly I've got Caribbean background, and that's very much what Bahamians would do, a family from Bahamas. Whereas there's a real valuing of aunties that we don't have in the West. And so we were wondering whether that extended family structure, and also a kind of desire to make one if you haven't got one, even if you're unaccompanied. I've actually recently met a young man who's an unaccompanied asylum seeker from Syria, but he's just getting in touch with local families. Can I have dinner with you, please? And then learn English, and he wants those cross-generational relationships. But what Rochelle Burgess was also pointing out to me was that sometimes communities can actually be broken by oppression. So her observation in Jamaica, for example, is there are certain communities that have never recovered from slavery. Some people became extremely violent and they became quite powerful, and everyone else in the community is just totally traumatized. So it seems to me that there's a kind of flip going on. I don't understand it. I mean, I'm just spitting, and of course, hardly anyone has done any research on non-Western communities. So if you want to have a research career, the world's your oyster. I really cannot believe how much we forget in the West about grannies and aunties. It's like, just ask about them. So, yeah.
Is there a class differential there, though, do you think, in the West? In working class communities, you are more likely to have the structures of extended family, aunties,
Yeah.
who are not biological relatives that you call on.
I think that's true. I think in certain working class communities, but I think what's interesting is that, as professionals, as mainly middle class professionals, we forget about that. In our kind of attachment. I mean, I thought John Bowlby was amazing. But our Western 95% of attachment research comes from Britain and the US, and it's all about mothers and infants. It's as if nobody even thinks about fathers. Or I mean, there's a lot of work to do there, I think, to try and unpick some of these things, because we have to forget as well that Black children in the UK actually have better mental health than white children, and then by adolescence that's flipped around. So yeah, so we're also looking at physical outcomes. I've got a colleague, Daniel Kerr, who's looking at blood pressure in relation to ADHD and ASD symptoms in childhood. But what does this all mean clinically? And I think what it means is that if you've got a patient in front of you with a history of abuse or neglect, don't forget to think about trauma-related problems. So don't forget to think about PTSD, but and RAD and DSED, even though we don't have treatments for RAD and DSED yet, it can be really helpful, I think, to talk to your patient about, he's maybe got some problems with boundaries, or you've maybe got some problems trusting. Don't forget that some of the most key, common trauma-related problems are actually depression and alcohol misuse. And then don't assume that your patient's problems are actually trauma-related, because they actually may not, even if they've experienced trauma. First of all, they may not actually have any trauma-related problems. And second of all, some of their problems may be nothing to do with the trauma. It's so easy to remember if you've got a patient who's got a history of trauma, especially if you find trauma-related symptoms, that doesn't mean you should stop there, because these are the patients that are at higher risk of having problems with ADHD, ASD, intellectual disabilities, which we always forget about, tic disorders, etc. And this group are also more likely to have complex overlapping problems. So there's the whole double jeopardy. And then, of course, at this point, everyone's always just going, oh my God, where do you even start? But actually, and I suspect in this group, you're probably less like that because you work with children and young people with very complex problems. But I think just be systematic. And what I recommend is, if before you think about depression, anxiety, psychosis, for example, think first about neurodevelopmental problems. Make sure you don't forget to check about PTSD. One of the things Stephanie Lewis was saying this morning was that it's just remarkable how often people just forget to ask. And she wonders if it's that there's a bit of a taboo. We kind of don't want to go there because people have been traumatized. But, you know, you must. And it's worth thinking about, Rad and Dee said, you know, does this young person have a problem with seeking, accepting comfort? Do they have a problem with social boundaries and indiscriminate behaviours? Because just talking to them might help. And this does not have to take a lot of time. You know, you can do this as a multidisciplinary team. And my experience has been that often it's the children and young people who've been kind of either on people's caseloads for years, or who've bounced in and out of people's caseloads. It's like, oh my God, it's Janie again. You know, she's been coming to see us since she was 6, and she's back and back and back. And now we think she's got, you know, borderline personality disorder, and she probably does. Does she also have ADHD? Has anyone ever checked? What about her intellectual profile? And the way I like to think about this is in a very simple way, that for the actual formulation that you're going to do with your, you know, the patient, I think it's quite helpful just to think about this in terms of your make and your model. So not everybody wants a diagnosis right at this moment. The family may be resistant to that, or they may not. So you may want to think about, I'm a Toyota, I'm not a Honda. You know, I'm a person with ADHD. You know, I'm not a neurotypical person. Even if that's the case, even if it's helpful to you to think about yourself as a person with ADHD, that's never enough. So if you've decided that you are actually a Toyota, you can tell I love my crude metaphors. If you decided you are a person who's, you know, if you're a Toyota, what does that tell you? You need to know whether you take leaded or unleaded petrol. Do you have electric windscreens or wind-up windscreens? Do you have a sunroof? So in other words, it's not just the diagnosis might be helpful, but you've got to have a good formulation within that you can discuss with the young person, help them understand how they work, how do they function. And I just think more and more that is the biggest intervention that you can offer, is to have a young person really get an understanding, a real non-judgmental understanding of just what makes them tick, in a way that they realise that some of the things that have been problems can actually maybe be strengths in the future, for example. And that's really all I want to say, but I would love to know your thoughts. If you want to put your videos on, that might be really nice. Any questions from those of you who are zooming in remotely?
I just wondered about, you mentioned, sorry, Nadia, nodded it the proper way, so please.
Oh, you go first, and then.
As I said, you sort of touched upon it slightly, that I'm not clinical by background, I am sort of purely research focused, but a lot of the people, and in fact my friend's PhD was on borderline personality disorder or emotional unstable personality disorder, and quite a lot of people would often say, oh no, that's the wrong diagnosis for me. It's PTSD, it's complex PTSD. And I just wondered if you had any thoughts on the link between the two, really, because quite a lot of people with borderline do have sort of quite complex pasts and instances of trauma.
I mean, so borderline personality disorder, like most psychiatric diagnoses, it's just a way of describing a group of people with a particular profile. And, you know, the key things are problems with identity, problems with relationships, for example. And the research, my colleague Ruchika Gajwani has done a lot of work on this, and often there are other complex problems as well. So I mean, I'm not saying, when I say as well, I don't want to sort of get into a kind of debate about whether describing that as borderline personality disorder is better or not. For me, it doesn't really matter as long as you get a service. But what we found is that young people who fulfill those diagnostic criteria often have a range of other problems. Like sometimes it's PTSD, but sometimes it's neurodevelopmental problems like ADHD. And so I think really what I would say was, you don't want to stop there. You want to see what else might be in the mix. I don't know if that helps.
Yeah, no, it's just interesting because she actually quite likes her diagnosis, because for her it explains that. But I know when they she did a PhD with someone called Georgia Black, who experienced looked at the experience of borderline, and quite a lot of people saying, I really hate the label because it's quite stigmatized within services.
And Nadia, I think you had a question.
Yeah, thank you so much for the presentation. I'm going to try and word this as best as I can, but I was just wondering, in terms of asking these questions about neurodevelopmental conditions and PTSD, especially in places where maybe PTSD is not diagnosed as frequently. I'm from Egyptian background, and so I've noticed that in Egypt, like very rarely do people look at PTSD within those who have an intellectual disability and are nonverbal. And so I was just wondering what kind of comments you might have about that in terms of how we look at PTSD and those who are nonverbal.
Absolutely. I mean, it's not just in Egypt, it's also true here. And what I would say is, I don't personally have experience of, working with PTSD in adults with intellectual disabilities, but certainly with young children who are nonverbal, it is more challenging to diagnose, but it's not impossible. So, nightmares, behavioral repetitive play, for example, that's associated with something. So it sometimes requires a lot more detective work, I think, with people who are non-verbal, but it's not impossible, and it's certainly something that should be thought about. Yeah, I mean, I don't know if anyone here wants to comment on that. Any other questions?
When you talked about there being a lack of research around, did you say non-Western?
Yeah.
Does that mean, because I don't know, does it mean that there's a lack of research into how that might play into how they receive care and treatment?
A whole work is amazing. It's just incredible. And actually what really hats me off is that there is some really good research that's been done in African countries, and it ends up getting put in obscure journals. There's an amazing randomized controlled trial that was done in Uganda, and oh, that's okay. Thought we had a Uganda fan. And it was in Lancet Global Health. And I'm like, why is it not in Lancet? Do you know, this has actually got implications for the whole world. So there's a huge skew there, huge skew. But I do think at least the funding bodies are waking up to this, which is good. I noticed we're nearly at 5. There's probably time for one teensy little final question, if anybody wants to ask it. Go on.
So I know there's a bit of research on depression in the context of trauma, about it being more difficult to treat. I think maybe one of Montrose. Is that also the same with ADHD and like these other neurodevelopmental disorders? Is the nature and a treatment course and a prognosis different?
I don't think we really know. I mean, I think generally it's accepted that if you've got multiple conditions, it makes treatment more complex. But my hunch is the way to approach it is to just be really systematic. I mean, I've certainly got a colleague in Glasgow, in Edinburgh actually, who's a real expert in adult ADHD. And often adults with ADHD, by the time they're adults, they've picked up all sorts of other diagnoses because it's so stressful to be coping with untreated ADHD. And for him, he would always treat the ADHD first, even if someone's got substance misuse problems. But I think we were actually discussing this with Stephanie Lewis this morning. Other people would go in and try and treat PTSD first. And I think we don't know, we really have no idea. I suspect that the reason that treatment outcomes are not as good is because treatments have been developed for single categorical disorders and not taking into account these other things. So my hunch as a clinician is just try and be systematic. Whichever way you go in, just make sure you don't forget to take into account other things that might emerge once you've treated one thing. Does that make sense? Yeah.
Is it also worth saying that it might not be, like people might not have as good of an outcome because people get pigeonholed into really streamlined pathways? So if you are the kid with the ADHD, then you're in the ADHD pathway with an ADHD specialist who knows absolutely nothing about whatever other things you've got going on.
100%.
And then clinicians, we have I don't know what the red is. It's on the side. But we feel a bit proud, I think, is the word I would choose, in that we feel like in our own specialism, we can do this thing and treat this thing and expect all of these outcomes, regardless of whether or not we've addressed the other things.
100%.
Or even acknowledge that maybe other things are happening.
I'm so glad.
Yeah.
It's such, I mean, it's such a great way to finish, because I think that is the message for me. We've got to stop specialising. We really do. We've got to stop having our specialist Tourette's clinics and our specialist autism. We just got to stop all of that and just realise none of this is rocket science. It's not that hard to diagnose PTSD. You just look at the symptoms. Yeah, so thank you. That's a brilliant way to end. Couldn't agree more.
All right, thank you.